Hello, I'm Ian Flinn from the Sarah Cannon Research Institute in Nashville, Tennessee. I'm joined today by Loretta Nastoupil from the MD Anderson Cancer Center and Amitkumar Mehta from the University of Alabama at Birmingham. Well, maybe we can switch now and talk a little bit about CAR T-cell trials. There was some really exciting CAR T-cell trials presented this year at ASH, trying to move the therapy from third line, but basically those patients who relapsed after an autologous transplant or had refractory disease and weren't eligible for a transplant, to second line and replacing transplant. So I mean, there was this large international trial, the ZUMA-7 trial that compared Axi-Cel to standard of care therapy with salvage therapy and autologous transplant. Can you tell us a little bit about that trial and what your take is on the results? This was a plenary session study, so very, very important trial.
Yeah, you're right. Fred Locke presented in a plenary session, ZUMA-7, which was a phase 3 randomized trial of Axi-Cel versus standard of care therapy in patients with relapsed refractory large cell lymphoma. So in this study, the patients were randomized between two arms. One arm was the Axi-Cel arm, where they got lymphodepletion followed by CAR T, while the other arm was standard of care, that they got intensive chemotherapy followed by transplant. And these two were compared with a primary endpoint of event-free survival. This was the first study looking at head-to-head with the transplant in first relapse of diffuse large B-cell lymphoma. Most of the patients were primary refractory, so they had a relapse within a year of their initial treatment. And the study randomized 359 patients in these two arms, and a study met the primary endpoint of event-free survival between those two arms. So the event-free survival for Axi-Cel arm was 8.3 months, and for the standard of care arm was 2 months. Some of the highlight of the study, which is important to note, that the bridging therapy for those patients who were randomized to Axi-Cel arm was not allowed. Only steroids were allowed. So there were some comments whether the patients on that arm were selected who were not aggressive. So that's something to keep in mind. The other important Axi-Cel side effect profile was also consistent as published before. The CRS and ICANS occurred in a CAR T or Axi-Cel arm as published before. 6% patient had grade 3 or more CRS, and 21% had grade 3 or more ICANS. So in my opinion, definitely this will be a practice changing for primary refractory patients. As I mentioned, that there were debates whether we want to select those patients who are definitely refractory or relapse within a year, and those who can be handled just with high-dose steroid rather than bridging aggressive chemotherapy. So patient selection will be the key, but this might be used more in setting of first relapse refractory patients for Axi-Cel.
Loretta, do you agree? This is what we're going to be doing, and I guess maybe just dial down a little bit on the adverse event profile. They're different between a stem cell transplant and immune effector cell therapy, especially Axi-Cel. What do you think about that?
I think the key aspect of this study is this is really what is the best approach to second-line large cell lymphoma in a high-risk patient population. There's actually not a huge portion of patients in the control arm that actually made it to high-dose therapy auto transplant, reflective of the fact that, again, these are high-risk patients that have progressed early from frontline rituximab and chemotherapy, so not surprising that a large portion never make it. So it's really CAR T versus salvage chemotherapy, and then a portion of those actually go on to transplant. So I do agree, this is practice changing. Now, the challenge to that is, do we extrapolate? Do we now take patients that progress in 15 months or 18 months to CAR T in second line? I think we should probably still reserve it for these high-risk patients because they're the ones that we anticipated were not going to do as well with salvage chemo and high-dose therapy. In the safety profile of Axi-Cel, the treatment-related mortality was quite low, but again, it's not really head-to-head versus auto.
Because of the salvage chemotherapy that was in there, and
and the fact that a minority actually go on to auto transplant.
Yeah, I guess the other thing that was important, at least, is that you think, well, okay, you can just go ahead and get salvage with CAR T-cell if you don't you don't respond to the salvage chemotherapy and transplant. But clearly, order made a difference here, right? I mean, there is a huge difference, and not everyone could get to CAR T cells if they didn't respond to the salvage therapy. Yeah, I mean, I think that's another important part of this as well. I mean, there was this. If you look at the curves, right, that were presented by Dr. Locke, I mean, the control arm performed pretty much as you would expect it. I mean, less than 20% of those patients had meaningful progression-free survival, whereas the investigation arm, the CAR T cell arm, had roughly doubling of that. I mean, this was an impressive difference. It's not just a statistical significant difference. It's a clinically meaningful difference in my view. What's your take on that?
No, that is true. As I mentioned, that there was definitely a meaningful improvement, but at the same time, the patient selection is the key. And as Loretta mentioned, that it was a surprise to me that the patients randomized to the control arm, about 1/3 could make it to the transplant. So the patient selection, in my opinion, will be the key to see the best benefit. And there will be extrapolation. There is no doubt in a real world setting. And I also feel that in a real world setting, the control arms, usually on a clinical trial setting, they perform better than in real world. But the question remains that why only 1/3 patient could make it to the transplant.
Yeah.